TNT Open Mind Insights brings you powerful, authentic conversations, illuminating the path to better mental health care for all.
Okay, welcome, Kofi Abrampah. I'm so glad to be meeting with you and learning more about you, what you do, and kind of pulling out some insights that we can learn from about mental health and medications and kind of how we can serve patients better. So, welcome.
Thank you. I'm also very happy to be here. And I appreciate the invitation to have a sit down and have a discussion with you, one on one, and learn a little something from you as well.
Yeah, you can ask me questions too if you want.
Yes, of course, I'm ready.
Okay. So, I've heard that your friends say that you laugh a lot.
Yes,
Yeah,
because
why is that?
laugh is the best medicine, I believe. Because I mean, the alternative is what? To me, the alternative to laughing is either crying or being frowning, and it takes a lot more energy to frown than to laugh. So I
Yeah.
don't like to use too much energy,
Yeah.
so I laugh instead.
So it's more, optimized.
That's right.
It's an optimized treatment to
That's right. To
laugh.
keep my energy
Yeah,
for something more
yeah,
important.
and it's free.
That's right.
I'm not
Right?
sure there's any side effects.
No side effects at all.
Wonderful.
Maybe live longer
Yeah.
and look young.
Yeah, yeah. So, everybody, we're done with the interview.
Okay,
Laughter is
goodbye.
the laughter is the best medicine,
That's right.
and this is coming from a clinical
Pharmacist. That's right.
pharmacist,
That's right.
okay? Laughter. It's free, no side effects, keeps your spirits high.
Correct. Laugh all
Wonderful.
the time. Even
Yeah.
even when people are making fun of you, you laugh with them.
Yeah,
There you
and
go.
you can laugh at yourself.
Exactly.
Yeah, yeah, and it's disarming too. It puts
E-
people at ease.
Exactly.
So, that's he's already made me laugh before we even met.
That's right.
So that's
Yes.
great.
I remember yesterday.
Yeah. So wonderful. Now, I want to dig in a little bit about why it is that you decided to become a pharmacist. Now, you've got a long resume. You've done a lot of things from bodybuilding to pharmacy and geriatric care and sports medicine. I mean, you've done so much, but what is your motivation to be in this field of medicine?
Uh, I'll start off by saying I've always loved science.
Okay.
In fact, prior to pharmacy school, when I first came to this country, I should say, I wanted to be a pilot
Mm,
because I thought I liked cool stuff. I
that's
thought I
cool.
thought being a pilot was the coolest thing when I was a kid. So I wanted to be a pilot. But as life goes on, things change a little bit. I met my honors biology professor, and he took me under his wing and told me how to apply myself,
Hmm.
apply myself in his biology class. So I actually started off being more interested in science, in biology through him. Through him, I did some research. I have some published research, back in the day. um, and then during the research, I decided, you know what, maybe I should try pharmacy school.
Mm.
I called my dean of pharmacy, and she asked me, "Are you good in science?" And I said, "Yes, I think so." And she's like, "Okay, send me your transcript." Yeah, I sent her my transcript, and within few minutes, she called me and said, "Apply."
Oh,
I applied, and obviously, she already accepted me before I applied. So
wow.
I got into pharmacy school. This is after I got my bachelor's degree in biology. So I was a little bit ahead of the curve in terms of science
Yeah.
when I entered pharmacy school. So pharmacy school was pretty comfortable for me.
Yeah.
But my motivation for staying in pharmacy is that I love taking care of people. I like to see the results of what I do,
Mhm.
and I decided to become specialized in geriatric pharmacy because I felt that the geriatric population were underserved. And
Mhm.
when people talk about underserved community, they don't really include like old people. They include
Yeah. Yeah.
like homeless people or minority groups. But the geriatric population, if you actually think about it, or as a pharmacist, I see that if someone who is old come to a hospital sick, the level of treatment, to me, from what I've observed, it's a little bit less than if a child is sick. People care more when it's a child. People care more when the person is younger. But when you're old, it's like everybody's expecting you to be ready to go.
Oh my
So,
gosh. Yeah.
so they don't. The treatment is not, as urgent. People are now on their toes trying to get things done for you, as an old person. But my goal is to change that. So I decided
Wow.
to, specialize in geriatric pharmacy and become more knowledgeable enough to optimize their therapy. And so far, so good. I've been a board certified geriatric pharmacist since 2016.
Oh, it's been a while
It's
then.
been a while, yes.
Yeah.
I'm old.
Yeah. You're old?
I'm very old.
Okay. Are you geriatric yourself?
Oh, yes, there you go. That is a word. I'm geriatric.
Okay. But no, what is the cutoff? Like, what is the definition of geriatric?
Geriatric is 65 and up.
65 and up. Okay.
65 and above.
All right.
Depending on maybe the region of the world you are, it could be lower or it could be higher.
Oh, interesting. So it
Because
depends.
some people, the life expectancy is probably less than, if it's less than 65, geriatric is 55 or 50, right? So, but in the United States, geriatric is 65 and above.
Yeah.
Yes,
So it sounds like you saw that there was a need and
exactly,
you thought, I can do something
exactly.
in that. And so was it motivated on justice or just finding an area where you felt you could have an impact?
Yeah, I felt like, I mean, the what do they call it, baby boomers, right?
Yeah.
People are growing older, so the majority of patients are actually older people, older adults. So I thought, what better to do to be than to take care of people, way more people. So as a professional, if I'm going to be successful at treating people, then I should be treating majority of people. And
Wow.
actually, the people who need medical care are usually older people, right? So, in fact, at my institution, about 64% of our patients are geriatric.
Wow.
So as a business standpoint, I have a much higher, what is the word, job security.
Job security. Yes. That makes a lot of
Yes.
sense. And how fortunate that population is that someone as smart as yourself
Thank you,
decides to
thank you.
apply your
You're too
career
kind.
to um, serving them. And I literally have never heard of anyone um, designate geriatric populations as being underserved, but they absolutely are.
Absolutely. I mean,
Yeah.
I see it almost every day, and sometimes I laugh with my colleagues about it because when somebody is like really, really ill and the patient is not doing well, people are not running, as much
Oh my
as
gosh.
if a child is like
Yeah.
coding or something. Everybody is,
Yeah.
like running very fast to to make sure that the patient makes it. But
Yeah.
an older person, everybody's like, okay, well, maybe she or he lived enough. So
Yeah.
yes, and it's definitely true. And it is something that we should bring awareness to,
Yeah.
so that we can better take care of our older people.
Yeah.
And I would say that I say this, I love old people because I was raised by my grandmother.
I was just going to ask you, where does that understanding and empathy come from for the
Yes.
older population?
Yes, I was raised by my grandmother, so everything that I know is because of her.
Hmm.
Yes.
Yeah.
Yeah,
Yeah. And so she had a great impact in your life because she
exactly.
raised
So
you.
I want to give back to
Yeah.
grandmothers.
Yeah. And it is a cultural thing for us in the United States
Mhm.
that we don't value our elders like other countries and other cultures do.
That is definitely true. It is quite the opposite in my country, in Ghana. Most majority of elders are basically worshipped. They
Mm.
are treated as, even when they are wrong, you are wrong first.
Oh my
You so apologize,
Wow.
even when they are the one that are at fault,
Yeah.
because they've earned the dignity to be alive and taking care of you and all that.
Wow.
Mhm.
Can you give me an example of what caring for older adults looks like in Ghana? Like if you have an older adult, maybe 80 years old, who's sick,
Mhm.
what does the care look like for that person?
Well, I wouldn't say it's better than here. I don't think it's
Okay.
better than here, honestly. Like caring for older adult, I think universally, it's not
Not as good.
it's not as good because of
Okay.
the what I said with regards to people see them or they're old, so maybe the reason why they are sick is because they're old,
Yeah.
right? Versus somebody who is very young and they're sick, and everybody is trying to make sure that the illness is taken care of rather than oh they are sick because they are young.
Yeah. Which
Exactly.
is not true.
Exactly. But when you're old, you are sick because you are old, which is not true because there's some people with the proper treatment, they can live twice as long. You know what I mean?
Mm,
Yes. Mhm.
yeah, interesting.
Yeah.
So, what have you observed in terms of mental health difficulties in the geriatric population?
Okay. The one thing that I noticed with the geriatric population, um, they're not able to verbalize their mental health issues. For instance, they could be on so many meds and the medications are the one that is what causing them to have mental health problems.
Huh.
So, for instance, a patient could be on benzodiazepine for anxiety, right? And the benzodiazepine it has risk of fall, risk of death. So let's say a patient comes in, has an anxiety or is acting, you know, in a way that it's not considered normal. So a patient is acting up, for instance, at a hospital. Right away they give the patient like Haldol to calm the patient down. But
Mhm.
Haldol is an antipsychotic. But then you calm the patient down, and that the calming of the patient down is actually causing the patient to have delirium,
Oh,
right? So
gosh.
exactly. So this is sometimes what we do as a geriatric pharmacist is to make sure that patients are not receiving meds that they don't need. They're not
Mhm.
receiving meds like just because, for instance, a patient could be uncomfortable in bed in a hospital, and the reason why they are acting up, making noises or make whatever it's because they are uncomfortable. They need to get up and pee. They need to be turned or something. And then and nurses or the physicians will consider that as the patient is acting up, and then they'll order Haldol or Xanax, right? So actually, one of the things that we try to advocate is to stay away from antipsychotics for geriatric patients with behavior problems,
Hmm.
unless the antipsychotic is for actual psychiatric
Interesting.
issues rather than just behavior problems. Yes.
Oh,
Mm,
wow.
mm.
And then there's just how many of the behavior problems could be solved without medications?
Well, actually, a lot. If you once we focus on the patient,
Mm-hmm.
and that's why I wanted to talk about the four M's.
Yes.
Okay, this is a concept of treating that we use to treat the geriatric population. The four M's is mentation, medication, mobility, and what matters to the patient. So the most important part of the four M's to me is the what matters to the patient. So, for instance, a patient could have anxiety, depression, and the patient is on antidepressive medication, but the antidepressive medication causes them to be drowsy. But what matters to the patient is to be able to have fun with the
Mm-hmm.
grandchildren, for
Mm.
instance. So if what matters to the patient is to be able to have fun with the grandchildren and you're giving the patient things that make them drowsy, you're actually doing the patient a disjustice, right?
Wow.
Because what matters to the patient is not addressed. You're focusing on just covering up the depression, right, and not caring about the whole human being as a whole. Okay.
Mm-hmm.
Also, you can give a patient medication to address uh, a medical issue that has anticholinergic activity. Anticholinergics are associated with dementia.
Oh.
So if you give anticholinergics to an older patient, they have a high likelihood of transitioning to becoming having dementia. So
Oh.
but if a patient, an older patient has dementia, develop dementia, people just assume that they have dementia because they are old. Am I right?
Mhm.
But really, they develop dementia because they are on a lot of anticholinergic medications.
Mm.
So our goal as a geriatric pharmacist is to reduce the anticholinergic burden on a patient. So
Wow.
there's actually an anticholinergic scale that we determine this patient is on this many anticholinergic medication. We need to reduce it to reduce the risk of anticholinergic activity on the patient, and therefore reduce the risk of developing dementia.
That makes a lot of sense. And
Yeah.
for those of us that don't know, including myself, what does anticholinergic mean?
Okay. So anticholinergic, like for instance, something that is the opposite of stimulant activity. I'm sorry, it has a stimulant activity.
Okay.
Like Benadryl has an anticholinergic activity, right?
Okay.
So if you give a Benadryl to a patient because they're itching or because of they want to sleep, right? Because Benadryl causes drowsiness, right?
Mhm.
Benadryl has anticholinergic activity. If you give hydroxyzine to a patient,
Yeah.
it's also used for anxiety,
Okay.
right? Also has anticholinergic activity.
Okay.
Yeah. So those
So there's a list of
a lot of
medications that do
meds that
that.
can cause exactly that
Yeah.
can cause that has anticholinergic activity. Atropine is an anticholinergic, but there are drugs that have intrinsic anticholinergic effects,
Mhm.
right? So we want to reduce the number of drugs that the patient is taking that have those effects.
Yeah. Is this commonly known with doctors about this
Um,
causing dementia? Dementia?
dementia.
Yeah.
It is up to us as pharmacists, or as to at least the consultant pharmacists like myself, to educate the doctors that don't know. There are some
Yeah.
doctors that do know. There are some doctors that don't know. So
Okay.
our job is to make sure that we educate them so that they are aware, and so that when they are ordering, like, yeah, take Benadryl, because Benadryl is over the counter. You can buy it.
Yeah.
You
Yeah.
can buy it anywhere, and you just take a bunch of Benadryls, and then the patient goes from perfectly high functioning to a dementia patient.
Oh my gosh.
So
Wow.
yes,
Okay.
yeah, and one of the highest risk to me is the risk of falls, because falls are associated with high mortality. So
Mhm.
once a patient starts falling, they break a hip fractures are associated with high mortality. So if your grandmother is falling all the time, it is time to make sure that they are taking better care of. Maybe sometimes they are falling is because maybe the home environment is not suited properly for them, right? So we have to make sure that the home environment is okay. Maybe they are tripping on wires. Or they are falling because of the medication that you're taking it causes drowsiness.
Mhm.
And like I was mentioning, if the medication is causing them to have a reduced quality of life, are we really treating them? Yeah,
Oh,
yeah.
yeah.
So our goal is to make sure that we treat what matters to the patient. And as I mentioned, as an age-friendly pharmacist, my goal is to try to get people to become more age-friendly aware.
Yeah.
Yes, and
Yeah.
treat the older adults the same way, with the same care as we would treat the pediatric,
Yeah. Oh
right?
gosh. Uh,
And yes, I'm sorry. One of the other things that I think we don't pay attention to sometimes is that doctors, pharmacists all know that pediatric patients have different physiologic function, right?
Mhm.
Because they're children, their organs are not well formed.
Mhm.
The older adults are actually almost the same as pediatric,
Oh,
because your organs are declining.
okay.
So an older adult's heart function is declining. liver function is declining, kidney function is declining. So the medication that will be perfectly fine for me is not fine for them because they're not able to eliminate, process, metabolize those drugs the same way. So
Wow.
yes, so these are some of the reasons why we need to pay attention, like the same way as we pay attention to kids. Because in pediatric, in pediatric medicine, they pay close attention to the dosing,
Mm-hmm.
make sure that the dose is based on patient's weight,
Yeah.
not just 500 milligram of Tylenol. The dose will be based on exactly how much the patient weighs, and we make sure that the dose is appropriate. Because if you kill a child, it's a lot worse than I think in our society. If you give a child a medicine and the child dies, society sees it as very bad. But if an older person dies, she's old, he is old. You understand?
Mm-hmm.
So we want to try to stop that.
Yeah.
Yes.
Yeah.
So my goal or our goal is to make sure that we treat older adults the same way we
Yeah.
treat children.
Yeah, that makes a lot of sense, and I'm learning so much too. You're challenging things that I just took as I just assumptions that I had,
I
right?
see.
Assumptions about exactly what you're saying, like it's they're sick because they're old, or the idea of, dementia just happens because it's hereditary. Like I had no idea that your like your choice of medications could cause that.
Exactly.
And yeah, and also that the dosage probably needs to be changed to,
Precisely. Yes.
yeah,
Yes.
and it's not going to be based on body weight.
Exactly.
Yeah.
Exactly. Like older patients have low muscle mass. They
Mhm.
have high fat. So, for instance, if a drug is distributed in fat, the drug will be a lot more accumulated in an older person
Mhm.
than a younger person.
Mhm.
So because of the fact that they have more fat than muscle,
Yeah.
right? So these are all the things that we have to take into consideration when we are dosing for older people. Yes,
Yeah, there's a
to
lot
try
to
to
take into consideration.
yes, yeah, to
Yeah.
try to mitigate the adverse effects and mobility and mortality of the
Yeah.
patients.
But I love that even with all your technical knowledge,
Yes.
that your favorite M is what matters.
Yes.
That's so wonderful.
Yes.
And
Because
that's like can
what
drive the whole thing.
correct. If
'Cause
you start from what matters, you everything else falls in place. Because if what matters to the patient, like as I was saying, if what matters to the patient is to be able to go to the grandchild's recital, but then you think, oh, this you need this medication to address this medical issue you have.
Mhm.
And what matters to the patient is to be able to do something. But the medication makes them not able to do it.
Mhm.
Are you really treating the patient?
Yeah.
You're just treating a disease, not the
Yeah.
patient. You understand?
Yeah.
So our goal is to make sure that how we make decisions for the treatment of an older adult, it actually benefits
Yeah.
the patient, not just the treatment of a disease.
Yeah, and that's compassionate care right there. That's
Precisely.
quality of life.
That's right. That's right. Otherwise, what's the point, right?
Yeah, and you hear of older folks that won't go to the doctor,
Exactly.
and probably because they're thinking that they're not going to pay attention to what matters in my scenario, which may perhaps be contrary to the medication they're trying to give me.
Exactly.
Seems
Exactly.
pretty common.
Yes. I mean, it is. This is something that we are advocating now as age-friendly pharmacists. Is to make sure that people actually start from what matters to your patient rather than treat. Even in addiction medicine, I'm learning now
Yeah.
that a patient can come in and say, oh, I need my fix and I need my this, right? But if you once you use motivational interviewing to assess the patient, meet the patient where the patient is, you will notice that maybe what they really want is not just a drug. They need something that will make them, even get off the drug.
Mm,
Something is causing them to have a drug, right?
yeah.
Exactly.
Yeah.
And the same thing with the older adults. Sometimes they start off with hypertensive medication. The hypertension medication causes diarrhea, and then a physician orders something for diarrhea. So one problem compounds to now two problems. Now the anti-diarrhea medication causes constipation.
No.
Then you get constipation medication.
Yeah. Oh
So
no.
this is where we talk. This is what we call polypharmacy.
Oh.
A prescription cascade, where
Mhm.
you order one thing, and then it causes the side effect. It causes like a side effect, and then you have to you treat the side effect, and then you treat the side effect of the second one. So you start off with one medication, and then all of a sudden the patient is on five.
Yeah.
So if you look at an older person's drug list, some patients are on like 50 medications.
Oh.
Sometimes I wonder how their blood is able to
Oh my god.
process process that many meds,
Wow.
right? But if the older person is lucky enough to have a good pharmacist to review the do a good comprehensive review of the medication, they will be able to deep prescribe the medication and
Yeah.
try to make sure that what they're taking is really what they need,
Uh-huh.
and also help them live a much better quality of life.
Yeah.
Mm,
Yeah. And that's important. That's mental health. Quality of life is mental health.
exactly. So
So how do people find out what it matters to them? The motivational interviewing, or is there
correct,
other? Okay.
correct. Through motivational interviewing, you find out what is the real reason why the patient is seeing you,
Mm-hmm.
right? Then you will find out what really matters to them, and then you'll be able to address it appropriately. Like
Yeah.
if you know that this medication that you're going to prescribe is contrary to what they want to happen in their life,
Yeah.
then you wouldn't do it, right? But
Yeah.
if you don't know, and you're saying, well, your blood pressure is really really high, or I need to give you this medication to address the problem that you have,
Yeah.
but then you're not addressing what really matters to them. Yeah.
Yeah. I'd like to talk a little bit more about the addiction medicine piece of what you do. Like, what are you seeing out there? What are some of the solutions that exist for those that are geriatric and struggling with an addiction?
Yes. So this is what I am actually trying to learn more about, and that's why I am actually in this program
Yeah.
to learn more about the addiction medicine, because um, a lot of older people, in addition to being old, they have chronic diseases, right? Sometimes some of the chronic diseases require them to take opioids,
Mm-hmm.
requires them to take benzodiazepines. So if they have addiction, but then their chronic disease is causing them to take what their their substance use disorder is, it creates a very difficult situation for the patient and the prescriber.
Oh
So
my
the
gosh. Yeah.
goal is to try to get an understanding of what is really going on with the patient, and then address it appropriately, just like I said we do for children. Because children, if a child is sick, we make sure that everything is nice and fine-tuned, because any small mistake can be catastrophic in a child. But in an older person, catastrophe is not as a big deal, I guess. But we want to make sure that we make it the same a big deal as with a child.
Yeah.
Yeah,
So addiction still matters,
exactly.
even when you're 85
Correct.
in a nursing home.
Correct. Because it is young people
Mm-hmm.
who are addicted. They grow old. Some grow old. Not all of them die. Not all of them overdose. Some grow old and they go into nursing homes, and they need to be taken care of appropriately. You need to make sure that maybe the pain medications that they are taking is not contributing to their opioid use disorder, right? So we try to optimize their treatment so that the patient can continue to get better from the use disorder.
Yeah.
Mm.
And I know you just started the TNT addiction medicine track.
Yes.
So you're just diving into this topic, but what are you seeing as some of the solutions so far? Are you still working on that?
I'm still working on it, and
Yeah.
I mean, I think that what I'm learning is that it would be good for more pharmacists to get involved
Mm-hmm.
and learn about addiction, learn about treatment of addiction, so that you can better understand how to treat. Because
Yeah.
until I started here, when I see, the stigma on addiction, when you see people as, oh, why are they on drugs? Why can't they control themselves?
Yeah.
Like I learned just just recently that how the brain works.
Yeah, I did too. I
Like
learned this too.
as I learned the thing about the finger,
See,
right?
I learned that too in one
Yes,
of the interviews the
yes.
other day. Yes.
I will never forget this,
Yes.
right?
Yeah.
So, and I learned the importance of having the right people around you.
Mm-hmm.
I learned the importance of being well treated. I learned the importance of the patient is not able to just snap out of it or stop what you're doing, because if the same way you would not tell somebody, why do you have diabetes? Why can't you stop having diabetes? So these are all the things that I've learned as a pharmacist, and I think if more pharmacists become more knowledgeable, they will be able to also contribute to the care of all of our patients,
Yeah.
young and old,
Yeah.
especially the old people.
Yeah. Well, it's been such a pleasure talking with you. You give me a whole lot of
Likewise.
hope for, the future and what care can look like, and how medications play into quality of life. And just knowing that there's people like you that are kind of overseeing these situations and,
Yeah,
and kind of moving in such a positive direction for people's well being
right.
is just really encouraging and gives me a lot of hope. So thank you.
Right. Thank you for having me, and for actually, and I also appreciate the opportunity to sit with you. It actually made me think more
Oh,
about
good.
what it is that I actually do, and how I can be better at it.
Yeah, that's interesting, right?
Yes,
Just verbalizing it,
verbalizing
having
it,
the
talking.
conversation.
Yes,
Yeah, it's a form of reflection
yes,
through
yes.
a conversation.
That's right. Because sometimes
Yeah.
we learn and do things, but you don't see the full picture until you are actually in the process of doing it and having a discussion about it.
Yeah, I
Mm.
love that feedback.
Yes.
Thank you.
Thank you. And I appreciate you. Yes. Thank you.
And again, laughter the best medicine.
There you go.
And lastly, I almost forgot, and we'll squeeze this in earlier, but if someone wants to reach you or learn more about the work you're doing, how could they get in contact with you or your organization?
I see. Well, if you want to reach me, I am at, well, you can reach me on my website, on LinkedIn. I would say Facebook. My Facebook, you see bodybuilding pictures,
Yeah, I
but
know.
I'm on,
Yeah, it's great.
I'm on LinkedIn. My website is Cliniplex, CL.
And we'll link it below so
Yes,
people can
please.
go
Yeah,
in.
I have. That is my consulting company. So that's how I get my clients. I work with a lot of long-term care facilities where I do medication reviews and try to, like I said, try to optimize their therapy. I also do some teaching. I teach about geriatric medicine. So I do actually give CE uh, lessons for physicians to teach them how to treat and dose for geriatric patients.
It's fantastic.
Yes.
Yes. All right. Thank you.